So I just want to say boa tarde. Did I say that right, Samir? Thank you, Pablo, for inviting me. It's been a pleasure to be here. Brazil is beautiful. I've never been here before, and it's just fantastic. I'm also a little sad because Andrea Peretti was to give these lectures, and I hope that I can do as good a job as I know he would have done. He gave me many of his cases. He was a great colleague, and I'm using them for the metabolic talk that I'm going to give. So I'm going to talk about inborn errors of metabolism, pediatric stroke. I have 4 talks. Pediatric stroke. Okay. Sorry about that. So just to introduce myself, I work at Children's Healthcare of Atlanta. It's basically 3 hospitals within the city of Atlanta. We're about 700 beds, and we're going to be building this new hospital, this 4th hospital in the city, so probably approaching 1,000 beds. And so we do a lot of pediatric imaging. Oh, why am I having so many problems with this? I don't know why it's not. There it is. Okay. So, what is stroke in children? Stroke occurs between the ages of 29 days to 18 years. And what is a stroke? A stroke is when we have sudden death of brain cells in a localized area due to inadequate blood flow. We know that brain cells can survive without blood and oxygen for about 5 minutes. So we have 2 types of stroke in children: hemorrhagic stroke, which is when blood leaks out into the brain tissue, and ischemic stroke, when we have a clot and the blood is not getting to the brain. That's an ischemic stroke, and these occur in about 50-50 in the pediatric population. So here's some facts about pediatric stroke: about 2.3 to 13 per 100,000 cases of children per year. It has nonspecific clinical symptoms, which is why we have such a hard time diagnosing pediatric stroke in children. There are many stroke mimics that look like stroke, but they're not. Hemiplegic migraine, which is probably the biggest one, occurs in about 35%. Seizures with post-ictal paralysis occur in about 15%, and Bell's palsy in 10%. So our imaging is going to be very important in assessing children with acute stroke symptoms. So I'm going to start with hemorrhagic stroke, and all these abnormalities will, will lead to hemorrhagic stroke, with the most frequent one being the AV fistula or the AV malformation. Oh, I really am having there we go. So here's an example of a previously healthy child that developed an episode of choking and apnea at the daycare. And of course, the first thing that we think about was this child abused? Is there non-accidental trauma? And what you can see is the presence of the subdural hematoma. We have subarachnoid hemorrhage present. We always do a 3D CT of the head in children. We're suspecting a fracture, and everything looked negative. So when we're suspicious of abusive head trauma, these children will go on to MRI. So on the MRI examination here, you can see that what looked like brain parenchyma actually is a large vascular flow void. And if you look further down, you can see these very large vessels. And on the coronal image, this very large vascular structure. So we did MRA, and you can see these large anterior cerebral arteries going towards this abnormality. And on the MR venogram, we can see that this is venous in etiology. So before neurosurgery would do anything, they required that we do a cerebral arteriogram. And here you can see this abnormality, this vascular lesion that's present. But if you look harder, you can see that there's another lesion on the left side in the same area. And on injection of the posterior circulation, you can see that we have a similar abnormal large posterior cerebral artery with early venous drainage. And this is multiple AV fistulae in the setting of Osler-Weber-Rendu syndrome. And AV fistulas are in fact the most common reason for hemorrhagic stroke in children, unlike in adults where AV malformations and aneurysms are more frequent. So here's an example of a different kind of a lesion. This is a 6-year-old boy with seizures and right extremity weakness. And you can see this heterogeneous lesion in the posterior left frontal lobe and surrounding vasogenic edema. And I know that you all know what this is. This is a cavernoma. Oops, did it again, sorry. I'm having a very hard time with this clicker. Oops. Okay, there we go. Okay, so when you see a cavernoma, always be looking for additional cavernomas because they can be familial. And so on the T2, on the gradient echo sequence here, you can see that we have a second area of signal dropout. And this is due to the familial form of these cavernomas, which are autosomal dominant. If you can do susceptibility-weighted imaging instead of T2 star gradient imaging, I would recommend that because it is so much more sensitive and you'll be able to see a lot more abnormalities than you can just with the T2 gradient sequence. So this is an example of a child that came, 6-year-old with a droopy right eye. And if you look very carefully, you can see that there's this mass here that's iso-intense to brain parenchyma, and we also have some scalloping of the adjacent bone. So of course we recommended an MRI in further evaluation, like a new onset seizure. And if you look very carefully, you'll see that there's this asymmetric hypodensity in the left posterior frontal lobe. On further evaluation with MRI, we have this signal abnormality in the subcortical white matter on the T2 weighted imaging. There's no evidence of diffusion restriction. On susceptibility weighted imaging, we can see this focus of signal dropout, which corresponds to hemosiderin. And then right next to it, you can see that there's this worm-like structure, which corresponds to the thrombosed cortical vein. And this is a this is a thrombosis of a cortical vein in venous infarction. So we can also have dural venous sinus thrombosis that occurs, and this can be easily missed in children and young children because their dural sinuses can look normally hyperdense, but you just need to keep your eyes open and always consider venous thrombosis, especially if the child is very ill. So here we have these large transverse sinuses, and on susceptibility weighted imaging, we have this intense signal blooming, which tells us that we're most likely dealing with a thrombosis. On post-contrast imaging, you can see how the thrombus is not enhancing in the straight sinus that's in the vein of Galen, in very irregular appearance of those internal cerebral veins. We have the classic appearance that everybody knows, the edema and the ischemia in the central part of the brain, in the gray matter. And so we have vasogenic edema and cytotoxic edema from venous thrombosis. On the MR venogram, you can see that the straight sinus and the vein of Galen are absent, which confirms the diagnosis. So now on to ischemic stroke. The risk factors in children differ from those in neonates and adults. So the arteriopathies are going to be a large percentage of etiology of ischemic stroke in children, systemic conditions, cardiac disorders, infection. But just remember that in the majority of children, you're not going to find any underlying disorder, and that's what's so frustrating about these cases. So here is an example of metabolic strokes. So we just don't have ischemic and hemorrhagic, but you also have to think of metabolic etiologies in children. So this is a child with MELAS at 5 days of age. And here is the child at 5 years old, and now the child's developed this area of, just a second, I missed, there we go. So here the child developed this area of cytotoxic acute ischemic injury in the left occipital lobe, some extension into the middle cerebral artery territory. So when you have multiple territories involved, there should be a clue that you could be dealing with a metabolic stroke. And then this is a child at 5 years of age. And you can see here now we have atrophy that's developed in the left cerebral hemisphere. Looks like it's lost volume, but we have edema and diffusion restriction in the right basal ganglia. And then on the next study, we have additional areas of ischemic injury in the insular cortex and the right frontal lobe. So this is what happens with metabolic strokes. Multiple territories migrating and recurring. Genetic causes can also lead to strokes. This is an ACTA2 vasculopathy. So if you memorize this appearance, you will always be able to make the diagnosis. It's very characteristic. These children have an abnormality of smooth muscle, and they can develop this vascular disease with these aneurysms and also with congenital mydriasis of the pupils. This is a very distinctive appearance with dilated proximal ACAs, straight vessels in the anterior circulation in a very small and thin vertebrobasilar system. These children have multiple ischemic strokes, and this is the appearance that you can see on the brain MRI. The main differential diagnosis for these cases is Moyamoya syndrome, and the lack of classic Moyamoya collaterals also helps you make the differential diagnosis. So this brings us into Moyamoya disease. There's two categories, the Moyamoya disease, which is idiopathic, and we have these characteristic, this puff of smoke appearance that was described first on cerebral arteriopathy. What happens is we have a narrowing of the distal internal carotid arteries, the anterior and middle cerebral arteries proximally in this characteristic appearance. But more frequently, what we see is Moyamoya syndrome, which is associated with other conditions. These are some of the more common conditions associated with Moyamoya syndrome: neurofibromatosis type 1, Downs, children with cranial radiation, and sickle cell disease. So in this child, we have the classic signal abnormalities of neurofibromatosis type 1 with the optic nerve glioma. And if you look carefully, the flow void in that right middle cerebral artery is decreased. And we missed this for about 1.5 years because nobody was paying attention. When we did the CTA, you can see that the narrowing is confirmed, and this was just an example of Moyamoya syndrome. So sickle cell disease is the most common inherited blood disorder in the United States. It affects about 70,000 to 80,000 Americans, of which children are 40%. It's also the most common monogenic hereditary disease in Brazil. Approximately 700 to 1,000 children per year are born in Brazil with sickle cell disease, which makes it a public health problem here. And I'm sure many of you have seen these cases of sickle cell disease. So how does stroke and vasculopathy occur in the setting of sickle cell disease? Because it is one of the main etiologies for pediatric stroke. So it's important to know how this happens. These abnormal sickled erythrocytes adhere to the vessel wall and release these inflammatory cytokines, and this causes an increase in vasomotor tone in the vessel, which leads to this proliferation of smooth muscle and fibroblasts with a gradual narrowing of the vascular lumen, which along with platelet aggregation will lead to ultimate narrowing and occlusion. So this is an example of a 2-year-old with sickle cell disease that presented with left upper extremity pain, initially thought to be sickle cell crisis. She began dragging her left leg, and we did an MRI. And you can see the signal abnormality in the watershed distribution of the white matter, evidence of hemorrhage that you can see on susceptibility weighted imaging, and the diffusion restriction corresponding to the acute stroke. On the MRA, you can see the classic appearance of moya with a narrowing of the distal internal carotid arteries and the proximal A1, M1 segments of the anterior and middle cerebral arteries and the collateral vasculature. So the child went on to transfusion because this is how we treat acute stroke in the sickle cell population, and was doing great for 2 years, but then came back again with the same symptoms, and now the child developed another acute stroke involving that right frontal lobe cortex. We repeated the MRA, and you can see the progressive vaso-occlusion that occurred within that 2-year period. So I just want to say a couple words about performing time-of-flight MRA in the sickle cell population. So this child here, we knew had an absent internal carotid artery, but we were concerned when we did the MRA that there was this narrowing of the proximal segment of the right anterior cerebral artery, because the left side of the brain clearly is perfusing across the anterior communicating artery. So this was very concerning, and neurology wanted to get a cerebral arteriogram before we decided on any further treatment. And so the arteriogram was done, and you can see that it looks totally normal. There's no more stenosis that's present there. So we repeated the MRA with a TE now of less than 3 milliseconds, and you can see that that vessel is normal in caliber. So whenever we perform MRAs in the sickle cell population, first, we always try to do them on a 3T scanner, and second, we always keep the TE below 3 milliseconds in order to decrease the flow, the loss of signal due to the turbulent flow that these sickle cell patients have. So the next group of disorders, CNS vasculitis, this is when we have an inflammation of the blood vessel wall, and it can result in a stroke in children. We have 2 categories, the primary vasculitis and the secondary vasculitis. So this is a child here with polyarteritis nodosa that has this area of acute ischemic infarction, and you can see the beating involving the external carotid artery vessels and also internal carotid artery, internal cerebral arteries, anterior. So this is a child with an infection, because infection can also result in a vasculitis. And here we have this mastoiditis. You can see the flow void within that internal carotid artery asymmetrically smaller, involvement of the cavernous sinus. We have an abscess present here. The child was developing neurologic symptoms. So we also did the MRA to get a better look of that artery. You can see that the whole artery there is narrowed, and on the diffusion imaging, there was a small focus of diffusion restriction. So just note that infectious etiologies can also secondarily involve the vessels and result in a stroke. This is an important category that's become much more well-known and better recognized in children, focal arteriopathy of childhood. And what you see here is an acute stroke in the right basal ganglia, and on the MRA, this irregular beaded appearance of the artery and a narrowing of that internal carotid artery. This is a very classic presentation for focal arteriopathy of childhood. It is the most common arteriopathy in pediatric stroke. It's acquired, unilateral, intracranial, like I said, involves distal and internal carotid artery and the proximal, middle, and anterior cerebral arteries. It's associated with basal ganglia stroke, and there's no apparent cause. What we sometimes will do is what's called vessel wall imaging. Well, we will do subtracted pre and post contrast enhanced images of the vessels. And if you look closely, you can see, you look very closely, an enhancing donut here around that inflamed vessel wall. And you do not see that on the other side. You can see it right here as well. So we can use this. It's helpful in demonstrating vessel wall enhancement in cases of suspected vasculitis and focal arteriopathy of childhood. Arterial dissection is something that we see a lot in children. This is a 14-year-old previously healthy boy. He became dysarthric with right upper extremity weakness while playing golf. We did the MRI of the brain, and there's a signal abnormality in the basal ganglia with diffusion restriction. And on susceptibility-weighted imaging, you can see this prominent focus of signal dropout that corresponds to the thrombus. So susceptibility-weighted imaging is very useful to us. You can see here on the MRA the narrowing of that distal internal carotid artery. The 3D CTA imaging confirms the occlusion in the artery. The neck vessels were normal. So arterial dissection is 4 times more common in children than in adults, and they can have purely intracranial dissections. Trauma history is minimal or absent. And another sequence that we do in evaluation of arterial dissection is this double inversion recovery sequence, which causes the blood to be very black, and we can actually make out the dissection around the vessel lumen. And here's another example of that. Normal vertebral artery. Here we're not really sure what's going on, but with the black blood imaging, we're able to see a patent vessel lumen with the dissection around it. So we'll use that also as a problem-solving tool. We do perform emergency treatment for acute pediatric stroke. And what we have available for children is the thrombolysis with TPA if the child presents less than 4.5 hours from the time of event, and thrombectomy, which we can perform up to 8 hours after the time of event. But using both of these techniques in children is controversial, and so we'll do it just on a case-by-case basis. This is this protocol that we use at our institution. We try to get the imaging as fast as possible. So if MRI is not available because we prefer to do MRI, then the child will go on to CT and CTA. So the CT-CTA sequence takes about, or study takes about 6 minutes, and the MRI will take about 12 minutes. So it's disruptive to our schedule. We have to take the patient that was getting scanned off the table to put the stroke patient on. So we don't do it for everybody. It's only in the cases where neurology is actually going to do something about the patient. So we have to have these criteria: no more than 4.5 hours from stroke symptoms. Children have to be older than 6 months of age, no bleeding disorder, and no contraindication to treatment. into imaging. And here's an example of a CT-CTA study. The CT, what we're looking for is low-density basal ganglia, and this finding can be very, very, very subtle, so you have to look carefully. Low-density basal ganglia, loss of the insular ribbon that you can see here on the left, but you lose it on the right, and what we call the dot sign, which is actually the thrombosed vessel that you can see in the sylvian fissure. The CT usually, however, is normal the first 12 hours after symptom onset. The CTA can show a little either occlusion or an area of relative narrowing that corresponds to the thrombus. The limited acute stroke protocol, the first sequence that we run is diffusion imaging. If the diffusion imaging is negative, then we just stop and the patient gets off the scanner. But if we have a positive diffusion study, then we'll move on to the rest of the imaging. On the flare sequence can tell us the extent of the signal abnormality on T2 weighted imaging. Susceptibility weighted imaging can show us where that thrombus is. It can also show us the extent of the brain that's at risk for becoming ischemic. And then the 3D time-of-flight MRA, where we're looking for the irregularity of the vessel or occlusion of the vessel. So I'm just going to give you two stories. This is the usual story of acute pediatric stroke that happens in my institution and probably in most institutions, unfortunately. So this is an 11-year-old, previously healthy, suddenly collapsed with slurred speech, left facial droop, and left-sided paralysis. So there's concern that the child's having a stroke, and we're about 45 minutes from the time of event. Remember, we have about 4.5 hours to successfully intervene. The child had difficulty breathing and had to be intubated in the emergency room. This head CT was read out as negative. Child went for an MRI 3.5 hours later because of the difficulty that the child was having, was in critical condition. So we did the imaging now at 3.5 hours, large area of diffusion restriction with multiple territories, anterior cerebral, middle cerebral, and neurology did not want to do anything because they were concerned that the stroke involved greater than 1/3 of the brain, which places them at increased risk for hemorrhage. And here you can see the MRA where the area of relative narrowing was. And so unfortunately, the child ended up having edema, neurosurgery had to do a craniectomy, and the child was left with this large area of gliosis and encephalomalacia. But now this is a happy story that I'm going to tell you. This is a 15-year-old with sudden onset of expressive aphasia, right-sided weakness, and history of congenital heart disease. The CT was performed about 1 hour and 10 minutes from the time of event. Now, there was a high index of suspicion because of the history of congenital heart disease. We did the CTA, and you can see that there is occlusion of the artery here. And neurology went ahead and infused TPA at about 2 hours and 10 minutes from the time of event, but there was no improvement. So they put the child in the ambulance and drove them to the university hospital for intervention, thrombectomy. And got to the university hospital at about 3 hours from the time of event, so we're well within the treatment window. On the CT perfusion, you can see this very large area of abnormal perfusion, a very large area of the brain that's at risk for ischemic stroke. At 4 hours from the time of event, the child had a thrombectomy. The thrombus was removed. This is the angiogram following the thrombectomy, and this is the child's brain at 1 month post-thrombectomy doing great. So in summary, we reviewed what the pediatric etiologies of hemorrhagic and ischemic stroke are, new information about childhood arteriopathies, look at techniques of vessel wall and black blood imaging to help you make the diagnosis, susceptibility weighted imaging, very important in acute stroke evaluation, and consider emergency imaging only if you're able to provide emergency treatment. So I just want to let everybody know that the American Society of Pediatric Neuroradiology is going to hold its first annual scientific meeting in South Beach, Miami, Florida, September 20th to 23rd in 2018. And I hope you all can make it, because it should be a very fun and informative meeting. Please feel free to email me with any questions and visit our society's website, because we do post a lot of interesting cases and information that you might find useful. Thank you.